introduction. I have the honor to introduce my friend, Professor Mohammed Abdallah. Professor Abdallah is a professor of clinical oncology, Qasr Al Aini Medical School. Professor Abdallah is going to speak about the updates in radiotherapy of early breast cancer. Please, Dr. Abdallah.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. I'm honored here, as usual, every year to be with you. Today, we are going to have some refreshment of what we know about radiation therapy of the breast cancer in the early stage. As we all know, breast cancer is one of the commonest leading causes of cancer-related death in women. However, over the past few decades, we have an increments in diagnosis in the age-adjusted incidence. This does not actually reflect the increase or more prevalence of disease. Rather, it means that we have better utilities for diagnosis and we can catch much more patients with sensitive techniques. Also, we have decrements. We have improvement of the disease-related mortality due to we have now a lot of the biological and insights of what's happening in the backstage of disease responsible for its aggressiveness, and we have a lot of targeted therapies tackling such a disease. So this improvement, when we are going to see in depth, and in most instances can be attributed to improvement of systemic therapy, while the local management, improvements in the local management is somewhat delayed to the back rows. This is right or wrong. That's what we are going to see in the next few minutes. Usually, local recurrences in breast cancer and the occurrence of distant metastasis are partially independent variables, and the presence of local recurrence does not herald the appearance of distant metastasis thereafter along the natural history of disease, except in certain situations where we have really what we call a high-risk breast cancer, as in young women below the age of 35, the presence of peritumoral invasion and the local recurrence within a short period of commencement of treatment, I mean within the first 2 years. This was the theme in the year 1995. As time is advancing, and 4 years later, we had a concept that local recurrence is going to be coupled with increase of the rate of metastasis all through disease spectrum. Now, as you see, the concept is somewhat changing. 6 groups had investigated mastectomy, modified radical mastectomy, versus breast conservation therapy, followed by radiation therapy. Of them, possibly the NSAPP and the URTC, they incorporate much number of patients, and they address that we are going to have a 10 to 20% incidence of local recurrence on protracted follow-up up to 12 years. Also, data from the Danish group indicated that still the risk of local recurrence is there in the early course of disease, I mean up to 6 years. So, can we have some data? Can we have how to utilize this recurrence, and can we prevent it to improve the outcome of disease to be reflected upon the overall survival or not? Data from the early breast cancer trialist collaborative group released in the year 2011, published in The Lancet, through analyzing data from 17 randomized clinical trials of early breast cancer with both positive and negative, incorporating more than 10,800 patients. Here, for any first recurrence, it was really down. It was lowered by the addition of radiation therapy to breast conservation surgery. And this lowering was quite significant at 10 years and reflected an improvement, significant improvement, and the gain was about 3.8% at 15 years for breast cancer death with addition of radiation therapy also to the breast conservation surgery. while the rate of death due to any cause, not cancer specific, also improved significantly with a gain of about 3%. And at that time, we had a clear statement that one death due to breast cancer can be avoided for every 4 recurrences prevented. When we go to stratify patients according to the nodal status, the benefit was still existing for node-negative disease. We have an improvement at 10-year, any event or any recurrence of about 15.4%, and at 15 years for the survival, cancer-specific survival, to be 3.3%. For node positive, definitely the value was there, and still we have great benefit. And this analysis, it was addressing the first event. It could be local recurrence, it could be systemic dissemination. Here, from this table, published also in the Lancet, that radiation therapy was capable of preventing the local recurrence that's going to be identified as a first event from 25 to 8%, which is, I think, it's nearly 1/3 the incidence of the incidence. While for the distant recurrences, and here we are usually talking about the systemic disease, we have just lowering from 12 to 10%. I mean, the value of adding radiation therapy is more powerful to control the local recurrence, and we can identify it or define it as the first event, and definitely this is going to be correlated with the extended survival at 15 years, as well as the local recurrence that will be prevented throughout the disease course. Coming to another question, can we omit radiation therapy from the course of breast conservation therapy? We have a lot of trials addressing this. I don't want you to go through the whole table, but when we are going to focus on the NSPB trial, this trial actually incorporated about 1,900 patients, and all the patients were of favorable prognosis. They have low risk of recurrence. They have disease, primary tumor less than 1 centimeter in diameter. All patients received tamoxifen for adjuvant therapy, and still, at 8 years, we can see that we have a significant increase in the rate of local recurrence, 16.5% versus 2.8% for those received the radiation therapy. It's about 8-fold. So, adding radiation therapy is quite important, and we cannot neglect it. Even when we proceed over time, and here we have the study published in the year 2001 to 4, where we had more improvements in the radiation technology. Yes, the rate of local recurrence was less, it's 2.7, while we are not going to give radiation therapy. While for those who received the radiation therapy, it was 0.7. Still, we have about 4 to 5-fold increase in the incidence of local recurrence if we are not going to give radiation therapy following conservation surgery. So, again, the question persists, can we spare some patients from receiving radiation therapy following conservative breast surgery? We have 2 major trials, the BASO trial and the PRIME2 trial. The BASO trial incorporated patients with lesions less than 2 centimeter, hormone receptor positive, grade 1, no nodal affection, and they underwent wide local excision with free margin, and analysis of the data showed that if we are going to give no adjuvant treatment, we have about 1.8% per year increase in the local recurrence, and it can be lowered by any of them. Still, if we are going to give both radiation and hormonal treatment, there will be no local recurrence. No local recurrence were recorded in this trial. For PRIME2, this was mainly for elderly patients over the age of 65, lesions less than 3 centimeter, again no nodal affection, but we have other risk factors as high grade, grade 3, or lymphovascular invasion. Any of them, but not both together. Also, patients with hormone receptor positive status included in the study received the TAM. Here, the 5-year ipsilateral breast tumor recurrence was about 0.6% as opposed to 2.7%. Still, no significant difference in the regional, contralateral, or distant recurrences, although the rate of local recurrence was improved. Also, the death reported in this trial was not linked by the breast cancer in the majority of patients. We should not forget that we are talking about rather elderly patients. Coming to the role of radiation therapy after mastectomy, where we have a lot of debates. Again, the Early Breast Cancer Trials Collaborative Group released its meta-analysis for many trials, released about 6 months ago, published in The Lancet in the year 2014 at June. For patients with node-negative and early disease, there was no difference adding radiation or not. Even it was reported to have a loss at extended follow-up, loss of more patients of about 1.3%, and this could be attributed to the toxic events or the cardiologic toxicity expected to be encountered with radiation therapy, especially if we are going to include the internal memory or something like that. Also, we should not forget that most of these patients were analyzed in the early days of 2D radiation therapy. Most of them were not treated by 3D technology. But look here, when we are going to consider the positive lymph nodes following mastectomy and axillary dissection, definitely there is a beneficial effect expressed in significant lowering of the local regional recurrences with addition of radiation therapy. Also, we have improvement in the any first recurrence over 10 years, and at 20 years we have significant improvement when we consider breast cancer mortality as a cause of death. Stratifying patients according to the number of lymph nodes, again, the benefit was maintained for those with 1 to 3 lymph nodes, as well as more than 4 lymph nodes to be affected. Again, we can ask another question. Could this improvement attributed to the use of systemic treatment? Analysis from this trial showed that for patients with 1 to 3 lymph nodes positive following mastectomy, axillary clearance, and received definitely systemic therapy, addition of radiation therapy improved the local recurrence, the first recurrence anywhere, as well as the breast cancer-related mortality. So, we can say clearly now that postoperative radiation therapy is indicated for most of patients following breast conservation, for the majority of patients. Still, we can spare some patients aged 70 or more, node negative, stage 1, I mean no high-risk factors, and they should be under endocrine therapy. Following mastectomy or the modified radical mastectomy, we have our classical indications of having a big T disease, T3, T4, and positive margin of invasive component of disease, or patients with more than 4 lymph nodes, and we extend the indications to include those with T1, 2 disease with nodes positive 1 to 3, T3 and 0, the presence of ductal carcinoma in situ at the margin, as well as those with triple-negative breast cancer, and this in particular is going to be addressed in the next lecture by Professor Twigley. We should not forget patients receiving neoadjuvant therapy. Here, following the surgical intervention, they should receive adjuvant radiation therapy. Moving to the issue of the fraction size, fractionation, and the overall treatment time, most of our routine practice now, based on the UK data of START trial, published in the year 2013. Classically, patients with rather early tumor, T1 to 3, with node 0 to 1, definitely M0. According to the routine theme adopted previously, they were going to receive 50 gray over 25 fractions in 5 weeks. And this theme is considered as the basic theme, while the investigational arms included. First, START-A trial, 2 schedules were tried, 41.6 over 13 fractions in 5 weeks, or 39 gray in 13 fractions over 5 weeks. And here, the 3 schedules were considered identical to each other, no statistically significant difference in terms of the loco-regional recurrence. The other study, which is START-B, 40 gray in 15 fractions over 3 weeks, and also we have no statistically significant difference between both schedules in terms of the recurrence, loco-regional recurrence. For disease-free survival, for the first trial, START-A, no difference. But here, for START-B, where they used the 40 gray schedule, we have improvement in disease-free survival, and it was significant, 0.022. Again, talking about compliance and toxicity, for the START-A trial, the 3 schedules, most of the data were in favor of the 41.6 schedule, in favor of the 39 gray, while the majority of patients were not in favor of the 41.6 as opposed to the 550 gray as the principal dose. While for the START-B, the 39 gray, most of the patients were doing fine regarding the early as well as the late side effects, favoring the hypofractionated schedules. So, 40 gray in 15 fractions in 3 weeks now is the most accepted and most widely practiced. Still, we have questions to be answered regarding the efficacy and the toxicity of patients with large breast size, those with more advanced tumors regarding the TN stages, and also the tolerability when combined with chemotherapeutics and targeted therapies. Radiation boost, we should not forget, because it's routine following breast cancer conservation surgery, following the whole breast irradiation, or as an accelerated boost. Most of the beneficial effect is going to be found in the young age groups with high or high risk group following addition of the boost. However, if we are going to consider the hypofractionated schedule, the value of the boost still needs to be more addressed. Another area, which is the partial breast irradiation, although it is widely practiced, but it is considered by many of the guidelines and authorities to be used within the context of clinical trial. Here, the selection, usually the patient should be somewhat elderly, over 45, 50, sometimes 60, including invasive ductal carcinoma, no lobular invasive element. Lesions should be quite small, 2 to 3 centimeter as a maximum diameter. Nodes should be negative, and no lymphovascular invasion to be encountered. The results showed that from the most of the trials that the overall survival and distant metastasis risk are not significantly different. Definitely with partial breast irradiation we have worse cosmetic outcome, higher incidence of subsequent mastectomy. It will be needed in much more patients following this technique. The higher incidence of the post-operative infection as well as non-infectious complications are reported to be higher if we are going to deliver the partial breast irradiation through brachytherapy. Still, more trials are needed for patients with multicentric disease, pathologically involved nodes, bigger lesions than 3 centimeters, the presence of lymphovascular invasion, and we will consider that those patients with ductal carcinoma in situ, hormone receptor negative, HER2 new positive disease, hereditary breast cancer with positive BRCA1 and 2 to be less optimal candidates for partial breast irradiation. Here, according to the NCCN guidelines, it specifies the use of partial breast irradiation for rather elderly patients with T1 disease less than 2 centimeters, and the remaining of the guidelines are the same as the 3 groups briefly. Stop ولا كمل؟ قربت اخلص على كل حاجه. Moving to the intraoperative radiation therapy as an option to be adopted in patients with early breast cancer, especially in elderly patients. Here, radiation and surgery are going to be adopted on the same day, so there will be no protracted treatment time. Usually for elderly patients, I know 45 is not elderly, but this was the age adopted in the following the trials I'm going to show you now with unifocal disease. They were tried in two studies incorporating about 2,700 patients in the two trials, Target A and external beam versus intraoperative radiation therapy trial. And here are the results that the use of intraoperative radiation therapy was associated with significant increase in the rate of ipsilateral breast tumor recurrence. There was more breast cancer specific mortality, numerically but not statistically significant in the arm received the intraoperative radiation therapy. The overall survival was not affected. Definitely, we are talking about intraoperative. It's a focal therapy. We have much less grade 3 and 4 cutaneous complications, and the high-risk groups considered not indicated for such approach, grade 3 lesions, the presence of negative hormone receptors, and the triple-negative breast cancer. Finally, my take-home message that radiation therapy treatments still playing a major role following the breast conservation and for certain indications following the modified radical mastectomy. We have significant improvement of the local control and the cancer-specific survival over extended periods of time. The hypofractionation schedule start B trial, the 40 gray in 13 fractions over 3 weeks, over 15 fractions over 3 weeks is the standard of care. The TMR bed boost should be considered following breast conservation therapy. Also, accelerated partial breast irradiation and intraoperative radiation therapy should be taken with much caution, although the partial breast irradiation is widely practiced and should be within the context of clinical trial. Also, the impact of molecular intrinsic subtypes and genomic alterations upon determining the benefit of radiation therapy needs to be more defined, and thank you.
Thank you, Professor Abdallah, for the very nice presentation, and now the floor is open for discussion. Any question, please?
Thank you, Dr. Muhammad, for the presentation, and I would like to comment on the radiation following the recurrent the radiation of breast in the setting of previous radiation. For example, patients with a history of lymphoma or Hodgkin disease who develop secondary breast cancer, and there is some case reports and case series regarding the use of partial breast irradiation in this group of patients. So we could offer a conservative surgery for these patients. So
I think for patients with non-Hodgkin lymphoma as a primary disease, there is no place to go for extensive surgery like mastectomy. It's just for biopsy. Mainly the surgical role here is for biopsy. To adopt for partial breast irradiation or not, still it is not within the guidelines.
Yes.
Guidelines. No guidelines for this.
No,
we are talking about clinical trial.
Yeah.
Till we have the evidence, we should not use it except within the context of clinical trial.
Yeah, and my second comment with regard partial breast irradiation using the 3D conformal radiation is much more better with regard to the results of the cosmetic results as compared to the interstitial radiation.
As I said, that the partial breast irradiation used with either the external beam or the brachytherapy, yes, it's widely practiced, and we have a lot of literature now, but not go to the level to be included or considered as practice-changing guidelines. Still, till the NCCN, the last version, which is published about 2 weeks ago, it's still within the context of clinical trial. Should not be offered except if we have well-controlled clinical trial.
There is a big study, I mean, the NSABP 39 study.
I know, but it's not considered, I know the study, but it's not considered as a practice changing yet now. We have a lot of data we are using every day, but this is not within the context of guidelines.
Thank you.
Professor Abdallah, is there any role for re-irradiation in those patients who underwent breast conservative surgery and who developed recurrence after chemoirradiation, especially that those patients, most of those patients will receive, of course, irradiation and anthracycline containing regimen?
I think it will not be that effective, and we should not forget that we have some complications elapsing over time as fibrosis and shrinkage of the breast, that making the homogeneity of radiation therapy or the interaction itself, it's not known. So even it is not mentioned in the practice guidelines that you can re-irradiate. I think if we have recurrence following breast conservation therapy, the ideal treatment will be mastectomy, if possible.
Thank you. Can I have a question? Thank you, Dr. Mohammed, for your comprehensive talk. I want to ask you about the era of the new surgical techniques such as subcutaneous mastectomy. Is that the same indications for post-operative therapy?
Yes, it was stated clearly that the reconstructed breast or the flap should receive the full dose as a tumor bed.
Dr. Mohammed, for hyperfractionated radiotherapy, 40 or 15 or 42.5/16, those trial was for low-risk patients. What about high-risk patients? From my own practice, I still give 50 Ra/25 for the high-risk patient. What's your comment?
Yes. First of all, the 41.6 was not superior to the 40/15. Even in the long term follow-up, it's associated with worse cosmetic outcome. For the local regional control, they are identical, but for the 40 gray, it's associated with significant improvement of the disease-free survival, as I show you in the presentation. However, for high-risk patients and those following breast conservation, even we can use hyperfractionation schedule for patients with breast conservation if they will follow certain guidelines published by the ASTRO, that the central axis, the minimum dose should be 93. The difference between the highest and the maximum point should be plus or minus 7% only. This is, they were not tackling the high-risk patients. They were not tackling the high-risk patients. And even from this trial, published 6 months ago from the early breast cancer trialist collaborative group, there were more tendency to improvement in the local control favoring the 40 gray. In the subset analysis, when you go for the plot, you will find that the benefit goes to the side of the 40 gray schedule.